Hey guys, I'm Kevin Budashevsky, and we're going to continue our flow down the ureters. So the ureters are retroperitoneal and thus pass underneath the uterine artery or vas deferens on each side of their course to the bladder. You can remember this with the water under the bridge mnemonic, to keep in mind that the ureters, carrying water, or in this case urine, flow under the bridge. In this case, the uterine artery or ductus deferens, shown here. After this, ureters travel over the common iliac artery prior to entering the bladder. Therefore, the ureters go under the bridge and over the iliacs. These relationships play an important role in surgery, so this tends to be high yield on exams. During gynecological procedures, for example, involving ligation of the uterine vessels, the ureters may become damaged. Can you guys tell me what conditions may result from ureteral damage? Well, if you damage the ureter, it can commonly lead to obstruction. And can you guys tell me for bonus points what type of azotemia this would cause? Good, that would be a postrenal azotemia. Excellent. So this is if the ureter is accidentally surgically ligated, but what if the ureter is actually obstructed? Well, we see this happening commonly in the case of nephrolithiasis. There are 3 regions of the ureter where obstructions are more likely to happen due to purely anatomic reasons. Can you guys name them? Well, let's show them on this KUB. The most proximal region is actually in the kidney. Can you guys tell me where? It's in the renal pelvis. Now this should make intuitive sense. Just as large DVTs get stuck in the small capillaries of lungs because the lumen of the arteries and arterioles gets progressively smaller and smaller, kidney stones are more likely to get struck and cause an obstruction once you move from the larger pelvis into the smaller ureter. Note how much the lumen decreases here. The second location for obstruction is at the pelvic inlet. At this location, the ureters make a sharp vertical to horizontal turn as they enter the pelvic inlet. This kink in the ureter increases the chance of obstruction, so this would be shown here. And I want you guys to look really close and just notice the kink that we see in the ureter. Can you guys name the final kink in the ureter at which point a stone is likely to become lodged? Well, that's right, at the ureterovesicular junction. So here are the ureters here, and the vesicular, or the bladder, would be right here. So the junction between those would be the third and final point of nephrolithiasis. Alright, time for a flash quiz. On exam, you may come across a patient with the following presentation. 47-year-old female presents to the ED with a 1-day history of severe intermittent unilateral flank pain that radiates to the inner thigh, associated with dysuria or painful urination. Urinalysis is significant for hematuria, or blood in the urine. CT imaging shows a radiopaque area within the ureter. Any idea of what the most likely diagnosis is? Well, from our last slide, you may suspect kidney stones, which are insoluble deposits that lodge somewhere within the urinary tract, disrupting flow. They can be radiopaque, which is the stone we have in this case shown here, or they can be radiolucent, where they're dark and don't show up on X-ray. Do you guys know what the most common type of radiopaque renal stone is? Good, that would be calcium stones. They're also the most common type of stone overall.